Hi, I'm Dr. Brian Kaufman, a retired family doctor and a CLL patient myself, and the Executive Vice President, Chief Medical Officer, and the co-founder of the CLL Society. Michael, you want to introduce yourself, please?
Yeah, Brian, I'm Mike Joyner. I'm an anesthesiologist and physiologist at the Mayo Clinic, who for the last 2 years and a couple months has sort of repurposed my career to think about how convalescent plasma could be used to treat and perhaps even prevent COVID-19
So,
as the pandemic progresses.
so one of the things that CLL, as we're both very well aware, and everybody listening is a cancer of the immune system. And we've had very mixed responses to antibodies, and we've continued not to do that well should we come down with COVID. So we were very excited about monoclonal antibodies, but the virus has outraced most of those, not all of those. And now we're excited that there's some antivirals, but those can have significant drug interactions with the drugs used to treat CLL. Convalescent plasma was one of the very hot topics early on, and then kind of fell out of favor and now is back in favor. So maybe you can talk to us a
Right.
little bit about that history. And convalescent plasma can be quite different one batch to another. So explain
Correct.
that to us, please. Yeah.
Well, Brian, there's a several-fold way to look at this. When there's a new outbreak of a new infectious disease, the first source of antibodies is going to be convalescent plasma from infected patients who've recovered and then can donate. But typically, and this was certainly the case early in 2020, you don't know how many antibodies they have, you don't know how well the antibodies work, so on and so forth. But what we were able to show early in 2020 is that if we gave really all comers high titer or plasma that had a lot of antibodies, if we gave that to them early in the course of disease, so as soon as they hit the hospital, that we might show some efficacy. So the buried treasure for antibody therapy, no matter what the source is in the quadrant or the part of the map that is high titer or high potency plasma given early. And that seemed to actually be working pretty well. And there were some studies looking at patient outcomes from different groups, Hospital Corporation of America, Houston Methodist, and so forth, that suggested that worked. But then in early 2021 and in fact late 2020, some studies that were done that tested it later in hospitalization, people that were in the ICU or people that had been sick with COVID for 8 or 10 days, and really didn't show a lot of efficacy. But in those studies, they had subgroups of patients who'd been treated early and or were immune suppressed, people that did not make their own antibodies. And throughout this time, we collected a lot of case reports at various institutions that showed in immune suppressed patients and patients who weren't making antibodies for whatever reasons, if you gave them replacement therapy with really any kind of antibody, but convalescent plasma, they did better. And we published a paper in JAMA Oncology, the Journal of American Medical Association, focused on cancer patients, showing that in patients with heme malignancies, which lymphoma is one of those, as you pointed out.
Hematological blood cancers.
Yeah, exactly. Hematologic blood cancers, that you had about a 50% reduction in mortality in those patients treated with plasma. So things just kind of linger along, and then plasma sort of gets replaced by monoclonal antibodies, which are a great product. They're a standardized product. They can be manufactured. You know what you're getting, so on and so forth. But the problem, as you mentioned, is the monoclonals, after 3 or 4 or 5, 6 months, they get outsmarted by the next variant of the vaccine. And we just saw this in the last couple of weeks with the sovatelimab getting outsmarted by Omicron 0.2. And now we're in a situation where we have to say, what is the potential source of passive immunity or antibody therapy for folks like CLL survivors and people that have had rituximab and people who aren't making a lot of antibodies, don't respond to the vaccines. And what has been emerging, a narrative that is emerging, is that there is this now very potent plasma from people who've been vaccinated and then had a breakthrough infection. So it's got a more recent, it's got a kind of the old school antibodies to the original viruses, and then it's got a kind of an update or a reboot with the newer antibodies. And so you get what you would call broad spectrum antibodies that are very, very high titer. And while the studies are still sort of ongoing, there are case reports and case series coming really from all over the world showing that lymphoma patients and patients who've had, again, certain immune suppressing drugs, that when they're given this what we call hybrid plasma or vax plasma from somebody who's been both vaccinated and infected, that they do pretty well. That we have some pretty amazing stories and so forth. So I think there is some hope there, and I think this points to that we need a polyclonal, in other words, or a broad spectrum antibody solution for patients like you and the folks that will be listening.
Dr. Joyner, does it matter when they got the infection and which strain they were infected with?
And that's really the key point, is because there are survivors of recent infections who've been vaccinated coming online all the time. And because this is sort of what I call a farm to table medical product that our colleagues in the transfusion medicine and the blood banking community collect for us, that means we're just a few weeks behind or a few months behind whatever the most recent variant is. And one of the differences between the antibodies people make that can do that and recover from disease is that the antibodies you make compared to monoclonals, we're sort of sloppy antibody makers. And so we make things that are a little bit broader spectrum that tend to cover a few more variants. So it's a little bit like, for lack of a better word, sort of like fine wine, where the stuff that really makes the wine expensive are some of the minor characteristics and so forth, minor properties, minor chemicals in the wine. So we're able to get this broad spectrum material, and that's what's super exciting about this.
And it has to be high titer. So how does someone know the
Correct.
convalescent plasma they're getting if I'm saying I've been exposed, or how do you
know?
Where is this at? Give me, and
Well,
how do you
see,
know this?
so we've had great working relationship with Dr. Peter Marks and his team at Center for CBER, Center for Biologics and something at FDA. And Dr. Marks is also kind of the vaccine czar. And they've worked to say we have to have a minimum standard of titers or antibody levels through one of several commercial tests that the folks in the lab and the blood banks have. And what's really interesting about this, what we call vax plasma or hybrid plasma, the plasma from people who've been vaccinated and infected, is that it's typically 10, 50, even 100-fold higher than these minimal standards. And in fact, I was just talking to one of the people in our lab, and she told me that they have to double dilute the sample to even get it to register on the machines, which means it's about 100-fold higher. So in general, any product is under FDA regulations or scrutiny or standards that has to be at least X, but the material people are now getting is probably 10, 20, even 100-fold greater than the minimal standards. But that is one of the criticisms of plasma, that it's not a standardized product in comparison to the monoclonals or the antivirals.
Dr. Joyner, if I'm interested in this, and I'm actually personally interested in it, and I'm sure a lot of the patients that'll be listening to this will be interested, how do they find out more? Is there a clinical trial open, or how do we find out about this?
There are no clinical trials right now, but this sort of plasma is approved with a special note or a special focus on immune suppressed patients as part of an emergency use authorization for plasma by the U.S. Food and Drug Administration. And the blood bankers are now starting to have it in stock. And so if somebody were to get sick with COVID, they would be able to request that. And the availability is variable across the country, but the blood bankers are excellent at getting units from one part of the country to the next relatively quickly. And we do see that picking up. So I think that's happening. And again, mostly because this is seen as replacement therapy, and because we've demonstrated that the product is safe. There aren't a lot of trials going on. There's one planned for Europe right now. But again, we've attempted to ask the National Institutes of Health to fund trials, but they're less interested in this for reasons that are not exactly clear to us. And I think the other thing, Brian, that's really, really important is for people to make sure if they're eligible to get the Evusheld, the product that can be used prophylactically. And at least for now, that's covering the variants that are out there. Now, that may ultimately get escaped, but at least in the short run, that it would make a lot of sense to do that.
You know, I totally agree, and we advocate that all CLL patients, regardless
Correct.
of their treatment status, whether you're treatment naive, whether you're in a deep remission, you are still immune compromised and would benefit from Evusheld. That's extremely
And if you
important advice.
break through the Evusheld and get infected, irrespective of the Evusheld, then you'd be in a position where convalescent plasma would probably be the antibody treatment of choice. There is one Lilly antibody that's currently approved, but again, it's a single monoclonal, and who knows how long that will continue to show efficacy against whatever variants are out there.
Bebtelovimab, I think, is.
Well, I think my goal in my next life, I want to learn how to pronounce all these things.
Right. So tell me, a lot of these drugs are very time sensitive. And what you were suggesting earlier is the convalescent plasma works
Right.
better early in disease than later in disease.
Correct.
Is there a time frame? So I've just done the test, seen the blue strip come up. I test positive. What kind of a clock starts ticking?
As soon as you can, but certainly within 3 days is optimal. But one of the things we're finding, at least observationally, in some lymphoma patients, is that they get sort of smoldering disease. So they become COVID positive, they have fevers, they have some respiratory symptoms, but they don't get the full-blown horrible pneumonia picture. Now, many do, but some don't. And those people can be just treated whenever we see them. And that's where we've had some success that I'm aware of, again, different places where patients who've been positive for, months, even people I've heard about positive for 270 days, our case report on this topic, or even longer in terms of I think I'm aware of one patient who I think was positive for about 15 months. And everything was tried, but ultimately the patient got several units of again, this very high titer Vax plasma and did well.
Last question, because you teased this at the beginning. Is this a preventive strategy like Evusheld? Could this be used prophylactically? I know it's in short supply right now, so that's probably not an option today.
I think, Dr. Kaufman, that is the next frontier, to think about it, using it prophylactically. I think we have Evusheld now, and I think that's the way to go. But I think ultimately we may end up thinking about something like plasma as a prophylactic treatment. And more importantly, the question is, can people manufacture a material that is both very high titer, but also what you could describe as broad spectrum and adaptable as these new variants come online?
Dr. Joyner, the last word is yours. Any last message you want to give to the patients about convalescent plasma?
I think, my first patient in medical school back in 1984, when I went on the wards, was a patient with a heme malignancy, and to see the heme malignancies go from these, things that killed people very quickly to become almost chronic diseases has been one of the most amazing things in my, almost 40 years in medicine so far. And you hate to see us lose those patients when we have antibody therapy that could be useful to them if they get infected with COVID. And I hope down the road we'll have additional antibody therapies for our CLL and other heme malignancy blood cancer patients, so that we can get on top of whatever infectious disease threats that are out there for them.
I just say amen to that. Thank you so much.
It's been a great pleasure, and it's been it's a horrible situation, but it's a great pleasure to be able to work constructively with groups like yours on this super important topic.
Great. Thank you again.
Yeah, my pleasure.